We are live now.
Good evening, delegates and participants. Thank you for joining Shield Connect. And today we have two speakers from Thane who is going to speak on the topic role of DNA fragmentation in male infertility, Dr. Snehal Kohale and Dr. Sangeeta Kumar ma'am. So before we give a brief introduction, let me also introduce our page shieldconnect.in, where you can find detailed information regarding blogs. So you can check all the blogs that are written by the doctors who are linked with Shield Connect. Then we have a webinar page where you can enroll in this page, and right now you can see this webinar on our page. You just have to enroll yourself. And here, this is the live comment section. So participants, you can post your queries in this comment section. So at the end of the session, we can have a Q&A with our speakers for the day. And now let me introduce our speaker, Dr. Snehal Kohale ma'am. Ma'am has done MBBS, MS, DNB on obstetric gynecology, MRCOG from UK. Ma'am has done fellowship in reproductive medicine, and ma'am is clinical director and consultant and fertility specialist at OA Fertility and Women Care from Thane. Now let me introduce Dr. Sangeeta Kumar ma'am. Ma'am has done senior embryologist and IVF lab manager of OA Fertility and Women Care from Thane. Ma'am is H3 certified clinical embryologist, certified embryo biopsy practitioner for PGD, PGS, and fertility preservation certification done from ASRM. So I welcome you, both of you, ma'am, on our platform, and thanks for giving us your valuable time for this session. Thank you, ma'am.
Thank you, Nishan, for kind words of introduction. And then, without wasting much time, we will start today's session. So I'll just share my screen. Just a second. So. Yeah, just a minute. So yeah, this is really a very good academic platform by Shield Connect. And last time we have had a very nice interactive session on low AMH and other things. And here I've seen like they are more on discussing the practical points which we are dealing with. And as a clinician, here also we want to give insights about what is the role of sperm DNA fragmentation tests in the male infertility evaluation. Just a second, I'll just make a slideshow. Yeah. So basically, in our routine clinical practice, when we see, So today's topic, what we have chosen is a sperm DNA fragmentation in male infertility. So in this talk, basically, we will discuss why there is a need for the sperm DNA fragmentation test. Isn't it just a semen analysis necessary? And what are the special situations where we, require these testings, and how we deal with that after the results are there? And that's why here, to add it to more practicality, we are going to see our even the embryologist view also. Practically how it has been done. There are so many tests which are there. Which tests we should choose? How those tests have been chosen? How we categorize? So we are having the combined views, like what is the clinician's view that I'll mention from my point, and what is the embryological view that will be mentioned by Sangeeta. So we'll start accordingly. So as we know that male factors are responsible for approximately half of the infertility cases. The cornerstone of male infertility assessment is the routine semen analysis, which is guided by WHO criteria, different criteria. Currently, we follow 2010 criteria. Now, conventional semen analysis does not evaluate all possible sperm quality parameters and impairing its diagnostic competence. So due to variations in the sperm quantity and the quality, it is difficult to use just a semen analysis test to make it as a management decision. So several studies have found and overlap of the semen analysis results between the fertile and infertile male. So over the period of time, it has been seen that just a semen analysis is not enough. Then what next? How can it be further? What we do? So what comes in the research and all literature? So fertilization and subsequent embryo development depend on the inherent integrity of the sperm DNA. Now, some DNA damage can occur, which can be repaired in the cytoplasm of the oocyte. But when this damage exceeds the cytoplasm's repair capacity or threshold, infertility can happen. So basically, it has been seen that elevated sperm DNA fragmentation may affect fertility by hindering fertilization, early embryo development, implantation, and even the pregnancy. So basically, from the fertilization level till the whole pregnancy, it might affect at different levels. Now, how? So there are different literature search available, like how, when it is possible, like why there is the need for this SDF and infertility. What is the role? Why should we bother? So definitely, it is not. It will discriminate the infertile and the fertile men. There are so many studies available. We don't want to make it into too much, details of it. We want to see the practical aspect. So basically, it helps in the prognostication, especially in the IUI cycles, IVF cycles, ICSI. So it has been seen in the different studies that it gives us the thresholds. Different thresholds will tell us about the fertility potential. So some studies have shown that if more than 30% of the sperm have the abnormal chromatin, the fertility is hampered, which is independent of the sperm number, morphology, and motility. Means sometimes even the semen analysis can be normal. But still, if the damage is more than 30%, definitely there is a problem. Now, the fertility potential, there are different, now that Sangeeta will be discussing, like what are the thresholds, how we see about it. But in general, 84% of the male with DFI of less than 15% achieved a pregnancy during first 3 months in the studies. And then 10% of the male with a DFI less than 30% achieve a pregnancy during 4 to 12 months. And then 20% of the male with a DFI of 30%, they never achieved a pregnancy. So definitely it has a very significant role. And there are many papers telling the IUI outcome. So what is the correlations? When the DFI was elevated, the success rate of IUI was very less as 1.5%, as against 19% with the DFI values. Now, in the IVF studies also, IVF ICSI cycles also, there are different meta-analyses and different papers are available. It is showing increased in the miscarriage rates when couples are undergoing IVF and ICSI, those who are having high sperm DNA damage. So it has, as it is like a role in the fertilization and implantation, it also has further developmental role where it gives rise to increase risk of the miscarriages also. So there are reviews, systemic review and meta-analysis telling its association. So that is sperm DNA damage is associated with a significantly increased risk of the pregnancy loss after IVF and ICSI. And there is a clinical indication for the evaluation of sperm DNA damage prior to the IVF ICSI and a rationally for further investigation when there is an association between the sperm DNA damage and the pregnancy loss. So basically, it is like definitely it has a role, but there are certain what you can say, certain indications. Then only we generally prefer this testing. We may not blanket it for everyone. So for that, we need to understand what exactly is this DNA damage and how basically, we test it, how we detect it, and in whom. And then later on, I'll cover up like how we treat it, how we prevent it. So I think I'll request Sangeeta, I'll stop sharing my thing, and I'll request Sangeeta to go ahead about the pathophysiology of this, how the DNA damage can occur and how it has been tested. So over to Sangeeta.
So I hope it is visible.
Yes, yes.
Thank you, Dr. Snehal, and I would like to take this opportunity to thank Mr. Nishant, Sahiti, and the entire team of Shield Connect for this wonderful opportunity. And before starting, before getting to know about the sperm DNA fragmentation, the causes, the tests involved, a little about the sperm cell. So I couldn't go to the next slide. Yeah.
It's
so yeah. So the sperm cell, compared to the oocyte and the embryo, the sperm is considered to be robust in nature, and it consists of the head, the neck, middle piece, and the tail. So, but the major function of the sperm is the contribution of the genetic material and the centrosome to produce a viable offspring. Generally, the DNA is wrapped around the histone to form the chromatin, but in sperm, during spermiogenesis, what happens is the spermatid repackaging happens, where almost 85% of the histones are replaced by the protamen, and only a small 15% histone is bound to the DNA. And these protamines are small, positively charged arginine-rich nucleoproteins, and the presence of cysteine allows the formation of disulfide bond between the protamines. This helps in strong stabilization of the nucleoprotamine complexes, and which is very much essential for the sperm head condensation and DNA stabilization. So a compact sperm chromatin is essential for the sperm function as well as subsequent embryonic development. So in spite of all these compactions, still the DNA damage and the strand breaks can happen. And this sperm DNA fragmentation can be caused by the intrinsic and the extrinsic factors, and also due to the lack of DNA repair mechanism in the sperm, it is more susceptible to DNA fragmentation. And studies have already shown that DNA breaks are present in sperm from fertile men, but the level varies from one sperm to the other. But whereas the infertile men usually have a larger proportion of sperm with a higher level of DNA fragmentation. So the biological mechanism of sperm DNA fragmentation is caused by either protamination failure, that is lack of replacement of histones to protamine during spermiogenesis. So studies have shown that infertile men have a higher histone protamine ratio than the fertile men, and 5 to 10% of infertile men have a complete protamine deficiency. And the other is the oxidative stress, which can happen during the epididymal transit, post-ejaculation, that is presence of the leukocytes, immature sperms, abnormal level seminal plasma, antioxidants. And the last is the apoptosis, which can happen during maturation, either in the testis or in the epididymis. So this is the mechanism. Usually, the primary mechanism for sperm DNA damage is the DNA strand breaks, defective maturation, abortive apoptosis, and oxidative stress. And there is a compelling evidence states that oxidative stress nowadays plays a major role in the DNA fragmentation. So these defective maturation happens by either defect in the topoisomerase, which helps in the conversion of histones to protamines, or incomplete protamination can lead to DNA strand breaks. And also, usually apoptosis helps in the abnormal germ cells arrest, so that it doesn't allow the defective germ cell to progress to the further spermatogenesis. But in case if there is a failure in this, can result in other DNA fragmentation. And there are also external factors like the varicocele, cryptorchidin, systemic inflammation, and genital infection, aging, lifestyle, food habits, smoking, environmental toxins, and ionizing radiations can induce oxidative stress and can result in DNA fragmentation. So there are different types of DNA damage which can happen. It can either be mismatched the bases, or can be an absence of the base. There can be a base modification, or there can be a cross-linkage between the bases. There can be pyrimidine dimers, or it can be a single-stranded break or a double-stranded break. So there are various scientific papers which have showed that the sperm of the infertile men contain more DNA damage than the fertile men, and this sperm DNA damage has a negative effect on the fertility potential of these patients. And also, high level of sperm DNA damage correlates with poor seminal parameters and such as reduced count, motility, or abnormal morphology. And this is one study which shows the negative impact of high levels of sperm DNA fragmentation on the embryo quality. And this study states about the association of high levels of sperm DNA with the miscarriage. To summarize this, DNA fragmentation positively correlates with poor semen parameters, leukocytospermia, and high reactive oxygen species level, and many studies suggest that sperm DNA fragmentation could influence fertilization, embryo quality and the development, blastocyst achievement, and pregnancy rates. So male infertility solely plays role in is the cause for almost 50% of the infertile couple, and the contributing factors of male and female is up to 50%. But till date, we tend to evaluate the infertile men with a conventional semen parameters, and studies have also showed that almost 15% of infertile men tend to have a normal semen analysis. So this states that though we get to know about the count, motility, and the morphology, semen analysis does not predict the fertility potential and the success rate of the ART. So it's better to go ahead with a sperm DNA fragmentation test, which can help provide us with a reliable analysis of sperm DNA integrity, which may help to identify men who are at the risk of failing to initiate a healthy ongoing pregnancy. And this can also help in clinical diagnosis, management, and the treatment of male infertility. It can provide us with a prognostic value in assessing the outcome of assisted conception treatment, and it can also help couples make an informed choice regarding their course of treatment. So the indication of sperm DNA testing is in those patients who are unexplained or idiopathic male infertility, in patients with recurrent pregnancy loss, clinical varicocele, multiple failed IVF-ICSI treatment, poor blastocyst development, arrested embryo development, in patients with advanced age, and in those patients who are smokers or those who are exposed to harmful chemical substances. So there are various DNA fragmentation tests, but these are the commonly used tests. The direct tests are the tunnel and the comment assay, whereas the indirect test, where the DNA has to be denatured, and those tests are sperm chromatin structural assay and sperm chromatin dispersion test, or we call it as a halosperm test, and the comet test, where it is acid or basic pH is used. So basically, the tunnel test is nothing but it's based on the labeling of free hydroxyl NICs with deoxyuridine triphosphate, and the quantification of incorporated fluorescent DUTP is done. So it's seen by the presence of the green cells. So the comet assay is usually based on the electrophoretic separation of DNA, while the damaged DNA forms a comet-like appearance, whereas intact normal cell is intact. Sperm chromatin structural assay test. This is a flow cytometric method, and these are usually based on differential responses of fragmented and non-fragmented sperm nuclei to the acid treatment, which are stained with acridine orange, and the fragmented DNA are stained as red, whereas non-fragmented are stained as green. And the DNA fragmentation index is calculated based on the percentage, the number of red cells by the total number of cells. So the last is the sperm chromatin dispersion or the hollow test, the most widely used one. It's based on the principle that sperm with fragmented DNA fails to produce the dispersed DNA loops after acidic denaturation, which means that the normal sperm produces a halo, whereas the ones with no halo are abnormal. So the DNA fragmentation index is calculated by the number of fragmented cells by the total number of cells counted. And we do have, as Dr. Snehal had mentioned, the fertility potential. We have the threshold range here, but based on the clinical interpretation, anything less, the value less than 15%, it's considered to be normal sperm, where they can go for the natural and natural try that Dr. Snehal will be explaining. And greater than 20% partly explains there is an infertility problem, whereas 25 to 30% directly it's IVF and ICSI to be considered, and if it's greater than 30%, consider ICSI. So already this part Dr. Snehal has mentioned, but still 84% of the men with DFI of 15% achieved a pregnancy during the first 3 months. And the higher the DFI, that is greater than 30%, sperm has an abnormal chromatin, and 20% of the men never have achieved a pregnancy. So comparing different sperm DNA fragmentation tests, each test has its own pros and cons. Whereas the correlation between SED and tunnel, SED is found to be more sensitive than the tunnel test. And despite poorly correlated SED may discriminate men with the normal and the abnormal sperm DNA damage with almost 70% accuracy when compared to the tunnel test. So when we want to consider which is the best method for SDF, it all depends upon the individual clinic's choice, based on the instrument available, based on the trained personnel, based on the cost, and cost in terms of the reagents and the running time, and based on the validation and standardization and analysis subjectivity. So the main clinical as well as the treatment part will be done by Dr. Snehal. Thank you, Dr. Snehal.
Okay. Yes, thank you, Sangeeta. It was nicely described about all the tests and why actually the DNA fragmentation happens, then how we can, detect it. And now we will see basically next thing. Just a second. I think my screen is visible.
Yes.
Yeah. So I just will go to the next this thing. Once now we have detected. Now, as there was one slide like how we interpret. If it is like more than 30% directly, we go for the ICSI. Less than that, we might go for the different, depending upon the semen parameters and of course the female factors. We choose the mode of the treatment. But before that, we need to improve the functionality of the sperms. And then our focus of treatment here remains is what can we do to reduce this sperm DNA fragmentation. So basically, as we have seen its causes, its pathophysiology, our line of treatments would be majorly antioxidants and the lifestyle changes that will come to in detail. Then treatment of underlying condition like infection, varicose, and avoiding iatrogenic sperm DNA fragmentations. So we'll go one by one in detail, but I would like to show you this clinical algorithm for that. So whenever there is the infertile couple, and as it was rightly mentioned, like why we go for the evaluation of this sperm DNA fragmentation testings is these are all grade C recommendations. One is unexplained or idiopathic infertility. recurrent miscarriages, lifestyle risk factors, varicocele, and of course, recurrent IVF failures. So once we detect it's a high sperm DNA fragmentation, then if suppose it's a varicocele, we go ahead for the varicocelectomy because it has been seen that if in the cases of the varicocele showing high fragmentations after the varicocelectomy, definitely we see the improvement in the parameters. Then in the cases of the basically unexplained infertility or recurrent miscarriage or lifestyle, so what we tell them is we treat the approaches to lower the fragmentations, like recurrent ejaculation. We'll see that in detail. Antioxidants have been used. Lifestyle modifications like diet, good exercise, reducing the weight, and avoiding smoking, alcohol, other substance abuse, and control of the infection. If there are gonadal infection, that is also one of the reason infection and inflammation. So we give the antibiotics. And still, if it is showing the high levels of the fragmentation, then we go for the ICSI. And then if there is again recurrent miscarriage after the ICSI, again showing it, then sometimes there are now different ways where even for the ICSI we use different sperm selection methods, like sperm preparations with say density gradient method, or there are other methods like PICSI, physiological ICSI. With the help of the hyaluronic acid, we can find out a good sperms. And then also there are methods like magnetic cell sorting. So those techniques can be used to select the good quality sperms. And then, or otherwise, the source, the sperm source, that means it has been seen that when ejaculated sperms, they have more fragmentations, then we can use even the TISA, that is the testicular aspiration techniques. Okay, we'll see that one by one. So when we have seen different studies of the using oral oxidants, oral antioxidants, it reduces the reactive oxygen species and it reduces the oxidative stress. So it gives the increased in the live birth and the pregnancy rate, and there is a reduction in the DNA fragmentation. And of course, in some studies, they have not shown any impact on the miscarriage rate or the sperm count and the motility, but significant increase in the live birth rate and reducing the DNA fragmentations. So there are different studies available. So basically, the conclusion is short-term use, it is safer. So indiscriminate uses and high dosages should be avoided for the longer term, because then it something gives reductive stress. That is also not good. So definitely, as we see, so what are the things, like what are these antioxidants? So there are different preparations available. We have to choose a good combination antioxidants which contains like vitamin D, vitamin C, vitamin E, folic acid, zinc, selenium. And then, so minimum, the newer concept is of 60 days of treatment. So minimum 2 months of the treatment, not even the long term. And from the, so that is from the initiation of the sperm production to the ejaculation. Now, so one is to reduce the oxidative stress. Reactive oxygen species are reduced by this oral antioxidants and given for 2 months. The next is to decrease the leukocytes in the sperm, because even whenever there is an abnormal number of the leukocytes, definitely they increase the oxidative stress, and this leads to the increase in the DNA damage. And that happens mainly with the genitourinary tract infections, inflammations. So basically, important is to treat those infections. So there are different ways, like, antibiotics. So along with the antioxidants, what we give is antibiotics, COX-2 inhibitors, anti-inflammatory. So basically, genital infections to be treated. Even the subclinical infections also to be treated, mainly that is with aerobes, Neisseria, then chlamydia, ureaplasma, mycoplasma, and all that, Maggie infection. 10 to 20% of the infertile men have this. And generally, why it is called as subclinical, because cultures will be negative in 80% of the people. But definitely what we give is azithromycin 1 gram single dose. And then of course we tell them, so it's a combination. We treat both, of course, because it's a genitourinary tract infection. It can again have the recurrence. So we treat both. Then frequent ejaculations every 2 to 3 days. And along with that, antioxidants, because even zinc and all has an antibacterial property. So definitely it leads to 42% of leukocytospermia resolution. So definitely it is very good. So it's always better because it's a very simple and reversible cause, and we can very well easily treat that. Then, as I mentioned about the varicocele surgery, so basically here, so there are studies which, as I have mentioned, different studies comparing. So definitely when the SDF is higher in the varicocele male, and when we treat, we do the surgery, it has the benefits. So there are meta-analysis. So they have shown that SDF decreased after the repair. So that surgery, not every varicocele has to be repaired surgically, only when, so that is this, this helps us in differentiating where we can go for the surgery. Yes, of course, there are grades and clinical parameters, but at the same time, when there is a high DNA fragmentations, we would prefer surgery in them. Now, again, how we can reduce, as we saw that ejaculated sperms will have more fragmentations, and so it gives a less clinical pregnancy rates in the studies, but definitely the testicular sperms, because those stress is more when the sperm travels, and that's why testicular sperms have less fragmented sperms, and then it gives us a more clinical pregnancy rate. So DNA damage in the testicular spermatozoa is threefold lower as compared to the ejaculated spermatozoa. So there are different studies which is proving this. So different ways, the testicular aspirations, where it can give rise to good, fertilization rate, clinical pregnancy rate, especially live birth rate, and less miscarriage. So that is very important. Now, how what can we do to avoid very simple things, very practical? How we can avoid this iatrogenic DNA fragmentation? So we tell them for the frequent ejaculations, and that is a short abstinence period of 1 or 2 days, and this definitely reduces the dead sperms and the reactive oxygen species which are coming from them. So definitely we instruct patients to deliver specimens 1 to 2 hours before ART is to be performed. So we don't have to take very much, immediately as soon as the sample has been given, we should start processing it, okay, as soon as possible. We should not it should not be more than 2 or 3 hours. Just before the procedure, 1 to 2 hours, they should give the sample. Then keep a specimen at room temperature using appropriate culture media. Incubation time after processing should not exceed 4 hours, and that's why that is very important. And very simple points. And thaw cryopreserved sperms just before performing it. Again, the similar thing. So these, if it is a frozen sample to be used, just before the procedure, it has to be used. Now, this also, there are papers showing abstinence period and about the sperm processing. So serial ejaculation every 24 hours for 4 days has shown 25% reduction in the SDF, that is DNA fragmentation, and density gradient method which is used has given, so post 3 hours of ejaculation, it has given 44% reduction in the sperm DNA fragmentations. So these are few things. So now what we take from this, so what are the practical points? So basically what we have to remember is, in summary, so sperm DNA fragmentation provides information that is different and of better prognostic value than the semen analysis. So it is necessary, and sperm DNA fragmentation mainly occur during the sperm transit through the epididymis, and it is mediated by ROS, that is reactive oxygen species. Now, oocyte can repair single-stranded DNA, but not double-stranded DNA damage. Okay, so all damages cannot be cannot be repaired by the oocyte. And one more thing I want to mention here, that oocytes, only good quality oocytes, so oocytes from the patients having good AMH only can have better repair capacity. So it all even depends upon the oocyte repair capacity also. So that is very important. So simultaneously, when we consider the outcome, we need to see the female factors and especially the AMH part. Now, the sperm chromatin disruption test, as we have learned about different tests, is the simplest method. SCG is the simplest to assess the SDF in the routine clinical practice. Now, this SDF has a negative effect on the reproductive potential that we have seen. So even in the natural conceptions in vivo as well as in vitro. So strategies to reduce SDF, generally what we should use in the clinical practice, antioxidant therapy. So choose a good one which has majority of these antioxidants only for initial duration of the 2 months. If suppose we have started and still the treatment is going on, and we still need to continue. So ideally, it should not be continued for the long term. So again, if we are restarting the treatment after some gap, then give a gap to the antioxidants. Give it for 2 months, wait for some time. It should not be even excess antioxidants. That is also not good. Now, of course, very simple is the treatment of even the subclinical genitourinary tract infections, and it has to be treatment in both. If there is a varicocele and SDF combination, then treatment of the varicocele. Whenever needed, we can use the testicular sperms for the ICSI. Now, iatrogenic damage, to avoid that, what we tell is the short abstinence period, as we saw. Then laboratory sperm selection methods, as I mentioned, density gradient, magnetic cell sortings, and then PIXI, and also proper semen handling, not long term. Just, use has to be immediately once the sample is been taken, like that. Now we will see there is something called, SWOT analysis. That is, this has been provided by one of the recent clinical guidelines for the sperm DNA fragmentation test. So they have seen what is the clinical utility of this SDF. So that is something: strength, weakness, opportunity, and threat. So what are the strengths? So as we saw, so SDF testing, not for the blanket one for everyone, yes, but it can provide useful information in the specific clinical scenarios, only specific, like higher levels of SDFs were detected in the patients with unexplained or idiopathic infertility. So we have to remember these indications: recurrent pregnancy loss, varicocele, ART failure, and those who are exposed to lifestyle and environmental risk factors, meaning obesity, then improper diets, and then some heat exposure, radiation, chemical exposures, like that. Now, interventions used in the treatment of high SDF were associated with improvement in the fertility outcome. So definitely, once we correct it, we have seen there is an improvement in the outcome. But what is the weakness of this? No universally agreed upon cutoff value for SDF exists. So as Nita has mentioned, different studies, they have given different fertility potential. So we need to standardize the test, basically. The quality of evidence justifying the utility of SDF testing in this clinical scenarios is mostly level 3, level 4. So it was all grade C, that means level 3 recommendations. Few contradictory studies have been identified. So basically we require more studies also to justify it. And that's why we are not saying that it has to be in everyone like a semen analysis, but definitely in these specific population of patients, we have to go for it. Now, opportunities. So more research, as I said, more research should be conducted to clarify the utility of the testing and determine the appropriate treatment modalities in specific clinical scenarios based on, and that's why we need a proper standardization of these tests and proper reference values. Then threats. the routine use of SDF for male fertility evaluation has not been recommended by international societies. These guidelines are not inclusive of all the clinical conditions that may benefit from SDF testing. So still we need, it's a scope, and SDF is the expensive and it's not reimbursed by the insurance. Of course, any fertility related, it's not reimbursed. So that is there. So one, we have to standardize and make it, less costly. So then we'll be able to utilize. So basically, this was all overview. Thank you so much about the what is the need for the DNA fragmentation, and if at all, how we detect it, and once we detect, like how we should be, treating it. So I think we have covered almost all the aspects practically. We didn't want to go much into the theoretical detail, and then I think. We'll give over to Nishan to check if anyone wants to ask any questions so that we can discuss.
Sure, ma'am. Thank you so much for giving the detailed information regarding this new topic. So let me check if there are any questions.
Mm-hmm.
Till then, I have one question, ma'am. Is this a defrag test should be made routine along with the semen analysis test?
So as I mentioned in the last slide also, as of now, we cannot make it as a routine because still we need certain insights about it, and because it's a costlier test, because practically, so we cannot give it to the every patient as a routine semen analysis. Only when, as I said, like there is a ART failures. So recurrent IUI, IVF failures, recurrent miscarriages, and then patients having varicocele, and then if obesity, some of these lifestyle risk factors or some exposure to heat or some chemicals or carcinogens, then definitely we go for it, but not as a routine.
And can this test can also be used for azoospermia patients?
Usually in the azoospermia patients, basically we cannot, because then in the semen analysis, because I think Sangeeta will be able to tell you, because when we detect, we should be seeing the sperms, and generally we don't apply it to the testicular sperms, but still I think I'll request Sangeeta to mention on that.
So azoospermia, where we cannot in semen analysis, there is no sperm seen at all. So at least to do a sperm DNA fragmentation, we need at least a minimum number of sperm, because the more the sperm count we do, the total number of sperm cells we count, we get to know the exact value of how is the fragmentation rate. But in azoospermia, as there is no sperm at all, so it's no point in doing. And basically, azoospermic patients will tend to go for a, provided if the hormonal levels are fine, they go for the testicular aspiration. And as madam has suggested, the testicular sperm has a very low DNA fragmentation.
So yeah, there is no need of testing again on them, right?
Thank you for giving all these answers. And I cannot find any more questions available. So thank you so much for giving your valuable time with us on Shield Connect. And we would like to have more such interesting sessions with you, ma'am.
Yes, thank you so much.
Thank you so much.
Okay.
Thank you.
Bye, ma'am.